So first of all, I just wanted to say a big thank you for everybody that's come today. This is our first event like this, and I'm immensely grateful that you've all come along, especially after a long day at work. So thank you for that. I'm Helen. I'm the founder of the SheLeads Health group on LinkedIn. I'm 53 years old and I'm a very feral Gen X. I have 20 years experience delivering patient safety improvements and change to the NHS, and I'm delighted to be hosting today's event. I started the LinkedIn group SheLeads Health to create a community for women in healthcare leadership. We face unique challenges, but we also face unique opportunities. So it's a great place. It's a great thing to have a space where we can share experiences, support each other, collaborate on projects. And if you haven't already joined, then do please join us. And hopefully together we can learn and make a bigger impact on healthcare. And that's regardless of gender. So whilst it is SheLeads Health, it's really for anybody who is passionate about diversity in our community. At this point, I really want to say a huge thank you to Stacey and Erin and IO Associates. Honestly, since meeting them, my personal life has changed completely, and I will be forever grateful. But also they're sponsoring today, and I don't think I could have done this anywhere near as well without them. So I wanted to say thank you. And I'm going to take this opportunity to hand over to first Stacey and then Erin to just introduce themselves. So Stacey, do you want to say hi?
Yeah, thanks very much for the introduction there, Helen. That was lovely. But my name is Stacey and I'm the practice director at IO Associates. Myself and Erin specialise in recruiting within the EPR and clinical systems space. And as Helen mentioned, we are the sponsors of the meetup. So really excited to be part of this journey and see where it takes us.
Brilliant. Erin, do you want to say hi?
Yeah, hello, I'm Erin. Yeah, I work really closely with Stacey and we work within sort of EPR and clinical systems, as she said. A massive part of what we do is networking and building relationships, and it's so lovely to see some familiar faces here, as well as some new. This is a huge thing for us to be a part of, and we're so grateful to be a part of it and to be sort of in this world that we call our crazy space. So yeah, thanks so much for everyone's support, and we're really looking forward to being part of this journey.
Brilliant, thank you. Right, and now if we start introducing our panel. So first person on my list is Debs. You want to say hi?
Yeah, hi, I'm Debbie. I'm 38, so I'm in the millennial category, and I'm from Plymouth in Devon. I'm currently a professional services engineer at Bridgehead Software, and I'm responsible for the installation and configuration of our software in various healthcare facilities across the globe. And previous to that, I was a PACS and RIS team lead in a radiology department in our local hospital. So managing and maintaining radiology systems, upgrades and downstream services as their system specialist.
Brilliant, thank you. And Joanne, you're next on my list.
Thanks, good evening, everyone. My name's Joanne. I'm a clinical lead on the frontline digitization program at NHS and Healthcare IT. I'm a pharmacy technician by background, but I've spent a lot of my career in clinical research, service improvement, service evaluation, and clinical business change. I'm 45, and I believe that makes me part of the.
Okay, brilliant. Joanne, your mic is a little bit crackly just for me, so you might want to have a look at that while we're off, and we'll say hi again. Davika, did you want to say hi?
Hi everyone, I'm Devika Italia. I'm a pharmacy technician by trade, and I currently work as a clinical informatics specialist for NHS England. I act as a clinical safety officer on the programs that I'm working, that's Pharmacy First and Child Protection Information Sharing programs. Previous to NHS England, I used to work with Leeds Teaching Hospital, where I was a specialist pharmacy technician working in the pharmacy IT team. And I was responsible for implementation or upgrades of the clinical IT systems. I belong to the millennial age group. I'm 42 years old. And what would I say? Age is just a number here.
Brilliant. Perfect. Nicola, did you want to say hi?
Yep. Hi everyone, I'm Nicola Warburton. I'm also 38, so millennial. I'm the head of the Clinical Services Product Centre at NHS Blood and Transplant. So I look after a number of our programs that serve our kind of labs and kind of genomic testing type things. But I also head up the team that runs some of our critical national infrastructure for the UK in blood testing and result processing. Prior to that, I worked at the Christie in Manchester and headed up a software development type team and also the applications side of things. So I've kind of implemented PAS, EPR, PACS, RIS, you name it. I've been part of all of those teams. I've got nearly 18 years experience in the NHS, and I started my career as a data manager, struggling to find things on paper. It's kind of driven a passion for me to try and streamline and make things easier for those joining the NHS and to improve patient care. But that's me.
Oh, perfect. Anne, you're next.
Hello, I'm Anne. I'm the Medication Systems Manager at the Countess of Chester Hospital. So I look after the EPR, the stock control system, robots, automated cabinets, and basically anything that comes under the remit of pharmacy IT. I'm Gen X. I just squeaked in. I'm 59. I started work in the NHS in 1988 as a pharmacy technician, and for pretty much all my career, I've been fiddling with pharmacy IT and digital systems. Thank you.
Thank you. And then last but not least, Charlotte, do you want to say hi?
Hi, do you know what? The pressure was on to get that mute button off before someone says you're on mute. So we've done quite well with this. Yeah, Charlotte, I have got 20 odd years experience NHS frontline, and that's very much in that middle management, operational management perspective. So when it comes to systems and changes from that operational point of view, and then also 10 years in digital health. So the digital transformation of clinical pathways, mainly in the acute setting. And a bit about me, I am a Gen X and 50 years old. I'm post-menopause. I am an empty nest survivor and a procrastinator and a serial fabric collector. So as everything else, what my focus is really now is on how the workforce adapts to change in different environments as well. So really excited to be part of this and see where this conversation goes on, Gen X versus Gen Zs and everything in between.
Brilliant. Thank you. Thank you. Really, really grateful to have everybody here. We've got a great panel. I think you'll all agree. The chat we want to have today, we went to a cafe in London and we brainstormed a bit, and actually Charlotte came up with a doozy of an idea, I think, and it just makes us a little bit different than some of the other talks you might have been to. But it's a fireside chat to discuss how changes in healthcare affect different age groups, and addressing the unique needs of both the organizational level as well as the front line, and if age has anything to do with adopting that change. So just some house rules during the session. We'd encourage you to ask questions and comment. If the chat is in full swing, pop those questions and comments into the chat. If you'd like to be heard, by all means, put your hand up. But we're monitoring the chat, and when you're in there popping your questions and comments, tell us who you are, where you're from, what company you're from, or what trust or health board you might be from. But also, what would be really fun, if you're happy to share, if you can also add your age group or your generation group, because that sort of works in with the science behind this, because we're really interested to see if age has anything or nothing to do with adopting change. So well, without further ado, shall we get started on our questions? The first one on my list, I wanted to put to Anne, if that's all right, just because your experience sort of spans the sort of longest across your career, and we're curious, what barriers to digital change have you seen during your career?
Well, obviously the people, but it's not always what you might expect it to be. So I've seen mature student nurses who are in the older generation who haven't even known how to pick up a mouse when you're training them. And I've seen younger generation who don't want to pick up the mouse. So there's the same sort of barrier for completely different reasons. I don't think you can generalize across everyone. I didn't mention it before, but I'm also a psychologist in my spare time. What spare time I have in the NHS. I think the barriers are from the people themselves who perceive that the software is going to take over their roles. It's too complicated. The pace of change is too quick. Certainly I find that every app you have on your phone changes every month because there's pressure there to change, and it almost makes it impossible to work. Different software. We were talking before about Zoom because a lot of us aren't too used to using Zoom. Well, we use Teams and we use Zoom, and they're both different. So every time you go on one, you have to change your settings and remember where everything is. Then you go back to the other. So the disparity of different systems we're using, I think, is a massive barrier to getting people on board and getting people to be able to use the systems easily.
Yeah, that's a really good point. Absolutely good point. So I was going to just add, how have you personally managed this within your team? So these sort of things that you've come across.
It's most important. We're finding this with the software supplier at the moment. They provide the software and you have to work around it.
Right.
And that's so not the way to go. You have to look at the people, how they work, and see how you can support them, not give them something and expect them to work around the software, because they won't anyway. If you give them something they don't want to use or they think's complicated, they'll find a way around it that may be dangerous. So you've got to listen to the people.
Absolutely. I was going to bring in, sorry, go on, Charlotte.
Sorry, yeah, Anne, can I just come in there? In terms of that training then perspective, if we're looking at different age groups, like for me, you're right, I still use a 4-colored pen, even though I'm in digital transformation, I have this idea of what training should be like for my generation. Do you think we should be considering training for different generations within our workforce?
I think it drills down even more than that. We should be considering training for the individual and how the individual best learns and how we can best support people. Again, I'm old and I can use IT, but I've come across people of my generation who haven't got a clue what to do. So I'm not sure it's as simple as age groups. That may play into it a bit because obviously people who've been brought up with IT are more familiar with it around them, but we've still got to play to the individual people's strengths and how we can best train them.
Yeah, absolutely. And I know, Davika, you actually had an opinion on the age group thing. Did you want to come in here?
Yeah, you brought me at the right time here, Helen. I was just about to say something on this. So I would totally second what Anna's just mentioned. So in a Leeds hospital, I was part of the delivering the training, and I totally would agree that it don't have anything to do with the age. It's about how you are adaptive to change or how you can quickly grasp something. So different people would expect, their expectations is different. So for it could be possible that somebody who is quite young at age, they may be good at they may be tech savvy, they may be really good at grasping the mouse, typing faster than I do, but understanding the processes or experience that comes with the age, they may be lacking it, and they may need a proper channel to actually explain them what it's needed.
Yes.
Something with the older generation, even though it might be tricky with them to get to press the keyboard keys at the speed or anything like that, but once they're at it, they get that, and they get it really nice and thoroughly, and they just put it into the practice. So I would say it don't really have much to do with the training. But to answer the question what Charlotte said, I believe that there is different different things that's required for training, because different people adapt differently. Some people like it's like learning techniques, like visual listening. Some things are hands-on techniques. So
Yeah.
it's a variation that could be brought into the training package that would help everyone grasp it equally.
Yes, absolutely. And actually, Nicole, oh, you got your hand up, because I was going to say, I know you have something to say about this because we chatted about it.
I need to get myself off mute now. Yeah, I mean, a couple of things there. I think the training, if I can just go to that bit first, I totally agree. Training needs to be tailored to the individual, but sometimes that is an incredibly hard task to manage. You know, the community that I serve is across the entirety of England and overseas in some instances. So how do you do that training? How do you have not a one size fits all, but how do you deliver that when that can't always be face to face or kind of on an individual basis is a massive challenge that we haven't solved. So if anyone's got ideas, I'm all ears. The other thing I was going to mention was probably a couple of things really. Firstly, I've seen some of our newer members of staff, and I've been quite taken aback by a lack of what I would consider basic Microsoft skills. Now, that was something that was taught when I was at school.
Yeah.
But that's not coming through now. And I don't know whether that's a change in kind of education, whether that's the variety of apps that mean that people don't use what
there's too many apps.
If I need to type something, it's Microsoft Word. If I need to do some sort of spreadsheet or calculation, it's Excel. But that doesn't seem to be the norm anymore. And I've taken that for granted. And we've had to kind of take a step back in a number of areas.
Yeah.
But that, yeah, I guess kind of in a generational kind of space. Another thing that shocked me recently, we were doing a UK England-wide project and put a call out for product managers, and one of the people that had really kind of gone, yes, I want to be involved, I want to lead this, is in kind of the older generations, but she's front and center and going, no, I want to lead this, I want to drive this change, this paper-based service is not okay. And I thought that was fantastic. But if I'm honest, if I'd have put my money on who that was going to be, I would have said it would be millennial, maybe.
Yeah.
Yeah, but not the person it was, and I'd prejudged that wrongly.
People surprise you, absolutely. Yeah. So
we definitely do have that preconceived ideas, and I certainly do. I just, going back to the point that Davika made, I assume that everyone is quicker, faster, and smarter than me when they're from that young generation. And I think having come up with, brought up teenage kids that spend their entire time on Xbox or PlayStation, that's another debate, which camp are you in there? But in terms of seeing the speed at which they do something, I've automatically assumed that. But what I've realized is those skills aren't needed when we're talking about system implementation within a working environment in terms of that EPR solution or those shared care records, putting in actual meaningful data rather than that quick type. I think there's an absolute need for that skill. And I think it's just about getting that balance right. But yeah, that preconceived thing, Nicole, is absolutely where I would have said the same, in terms of an older person just not being that tech savvy.
Yeah, absolutely. And Joanne's got her hand up. Do you have something to come in here with?
Yeah, I want to go back to something that Anne said that I think is really important, and that's around the people having to work around the system rather than the other way around. So what we do know, and there's been a lot of research into this, around user satisfaction with electronic patient records, and there are 3 major factors that basically determine usability and user satisfaction with patient records, and they're the first one, that it can be personalized so that it meets the user's needs, so the system works around the person and not the other way around. Shared ownership, so that those people are brought into the program and are part of the governance and can and see what's in it for them. And the final one, which we've already talked about, is that they can become expert users of that system, so they know how to use it effectively and efficiently. And I think that is probably the main factor where age might come in, because as Charlotte said, you know, different people of different ages will have different needs, and I think some people might be more familiar with certain devices than others, but it's not really, that's not really a factor when you're looking at a system implementation. It's how well the system aligns to your process and not the other way around.
Yeah, that's a good point. And then just going back to Nicola, it was Nicola or Davinica, one of you guys said it was Nicola, about the training. How you got any ideas for training? It made me think, and it is off script a little bit, but I was just curious, are you guys feeling the fact that suppliers aren't yet going to site to deliver training the way we used to? So certainly when I first started in software, so in companies, we used to go out, we'd train in a room full of people. That training was always sort of face to face. We could see what people were struggling with. Now training is done on Teams and the likes. Are you guys finding that a struggle? You know, is that something we should be looking at as suppliers to change?
I think
Definitely.
yeah, I think from our programme perspective, because we're a huge programme covering the whole of England to implement electronic patient records, and what we've seen is there is a lack of capacity in the system on the supplier side and on the NHS side around things like training. So we need those people and we need those materials, but everyone is wanting the same resource at the same time because they're all doing huge deployments. And it's the same with you know, digital and data professionals, but particularly with training. An easy solution to fit around clinicians' time is to do it by Teams or to do it by e-learning. And sometimes that the message gets a bit lost in that.
Yeah. And Nicola, do you think the same?
Yeah, I was having an interesting conversation earlier today actually about kind of how you connect with people, and I wonder if there's something actually in how you connect with the system. I'm talking about that ownership and whether it's something that you just have to use or whether it's something you buy into. But it was the conversation was centered around actually how do you do things via Teams, and I don't understand the science around it totally, but it was along the lines of your brain is almost fooled into thinking you're making a real connection when you're talking via Teams or Zoom or in this kind of virtual way.
Yeah.
And actually some of the neurons are actually triggered by the mirroring and kind of face-to-face contact. And I wonder actually whether that might help buy-in on that. It's a challenge though, and how you do that.
It absolutely is a challenge.
It's almost been like a hub and spoke where some of you are together and it's facilitated.
Yeah, it's like talking to a wall. So I'm pointing at, you guys can't see, but I'm pointing at Anne now because actually Anne and I go way back, and back when I first started my career, I came to site and trained an upgrade. I think it was a JAC upgrade, and we had a classroom style upgrade, and when everybody was starting to tune out, I can remember distinctly they were chatting over me, and I was able to say, look, it's clear you guys need a break, go and have a break now. And when you give the training on Teams, you have no idea if someone's reading their emails on another screen. I mean, does anybody else feel that?
Yeah, I could come in on that one, Helen, actually. So I was going to bring in one point on that because when we were doing one of the system upgrades and it was going from the inbuilt system to web-based, it was quite a bit of a different, and it was going to be implied across all over the hospital, and it was a massive change. And likewise, as Joanne said, it was really difficult to go and do one-to-one training. So the package that we were developing was something interactive, and like you said, it's easy to lose concentration. And I would always give this example. It's difference between hearing and listening. We want people to listen, not just hear.
Yes.
That's what we want for when training as well. We want their attention. We want them to do get the things in. And also we are dealing with patient systems. They're going to be using the system in our absence, using it for the patient, and we want it to be used for the right care. So we would say is make it interactive. So what we had developed as the training package, which was again online package via e-learning, was we explained them everything and then put a little some some sort of task for the user to do, like interact with it, so they understand, and we know that they've stick the right answer, yes, then they have actually listened to us rather than just hearing it. So that's how we made it interactive. And at the end of the day, we have got like a test pack, and then we know that they've actually gone through it, and they've understood it. If the score was not nice, and they have to pass and get the certificate. If the score was not nice, we can actually go and explain in different methods of how they would like to do it. So that's how we take it, and that percentage will be very low. So that's how we manage this situation.
Brilliant. That makes perfect sense. So in terms of, while I've got you here, I might as well ask you, over your career, what do you think has changed sort of since you started?
So the example that I would like to give is my son one day mentioned to me, "Mommy, what is a 3D save button doing in your cupboards?" And that was a floppy disk. So things have changed a lot since over my career. We had, big, massive desktop computers to a single small boxes. Lots of things have changed.
Yes.
In terms of the changes that are currently happening, everything was paper-based, and from paper-based, we're moving to the electronic health records. This is something what I would say is quite a big change, involvement of artificial intelligence, and that gathering everything which is structured data, and that data being pulled in the reports, and those data analytics that's helping us provide the better patient care. This is where I'm seeing the health informatics going forward.
Absolutely.
And at the end of the day, is for the better patient care. So I would say, things have changed. We have improved a lot, but we are still not there. There is lots of scope to improve, go better, go further. So
so we've seen a lot. So specifically around training, I was going to bring in Debs here actually, because Debs, you've been both on the shop floor, but you also work for a company, and in terms of what's changed during your career, I think even in the time that you've been with Bridgehead, the way you deliver training has changed. Am I right in thinking that?
Yeah, I mean, firstly, I agree with everything that everybody said about the training and whether it needs to be bespoke for certain age groups. I don't. It needs to be bespoke for certain user groups, and again, highlighting what everybody's mentioned, that is an impossible task. If somebody has the solution to that will be magical. But I do honestly agree with the fact that you need to get out onto your shop floor and you need to talk to the user groups that your changes are affecting. If you don't give people a voice, you cannot implement successful change. That's the underlying key point. And you need to get the right people with your bespoke training, not just, not the directors of the IT, not just the system managers. You need to get the people who are on the front line, who are going to have to work with these changes and probably have issues down the line that are not going to be discussed at a higher level, because they're the ones that are dealing with it. So with e-learning, I mean, e-learning packages are great, and you can design those effectively for different user groups based on their abilities. But I think that sort of interactive functionality is something that really kind of keeps people interested and helps the information go in. But physically being there, if you can provide that e-learning with them, or you send some sort of ambassador almost to the site. What we've done here at Bridgehead is, when we delivered training, an e-learning package for one of our web portals, we actually visited the hospital themselves, and we sat down in a room, and we carried out one-to-one training with them. We went through the e-learning package. We supplied additional documentation, which isn't a generic document that people are going to fall asleep reading. It is interactive in itself. It's got screen grabs of the actual e-learning that they're doing. And I think if you can somehow compile all of that together, that's going to make for successful training.
Yeah, absolutely. I mean, if it's a given, isn't it, that we know that people learn in different ways. There's all fancy words for them and everything like that. And I suspect that that stays the same as we get older. Charlotte, would you agree?
Yeah, and I think I'm just going to pick up in the chat. There's a message from John there, and he talks about gamification, which is absolutely like something that is up and coming topic in terms of training, and also in our clinical pathways as well, and in our systems. So I think it's really interesting how, you know, that is the new way of communication for that younger generation, not, you know, I think they're the alphas that are coming up and the some gen something else. But anyway, but it's those younger generation, it's like, how can we now capture them? But my question back, I've been reflecting on this, is like, how does the leadership and management impact the type of system implementation, support, or, you know, just that whole support package around it? Does that have any bearing on the way that training and systems are actually kind of implemented? And I mean that from, you know, we have a lot of hierarchical still within the NHS in terms of, you know, the old-fashioned job titles that bring that type of commitment. But I guess to ask, yeah, if you've got an older manager, for example, that's leading an implementation, does their preconceived ideas influence the type of training that they offer their teams?
Well, that's a really good question.
Yeah.
Girls, does anybody want to answer?
I don't know if it's whether it's the age thing. I think it probably comes down to that individual's experience. If they haven't been frontline and they haven't had to experience a major change and the difficulties that have come with that from somebody else being in a position of leadership that hasn't helped them to navigate it, then they are going to produce exactly the same results. So you know, I would say if they have been through the pain themselves, they are going to make sure that nobody else has to experience it.
Yeah. Nicole, you went off mute. I think you have something to say.
Yeah, I mean, it was something that came up when we had our initial conversation, wasn't it, Helen? And it was one of the things I said, I'm really passionate about not doing change at people.
Mm-hmm.
It's not done at them. So like I say, you know, the thing I alluded to before, we've made sure that actually part of that core team it's a nursing service. So the people that are making the decisions about what we deliver are 2 nurses. That we will have digital champions in each of our sites, because I think there's 11 different sites that we're going to be serving, and we're going to do road shows and go around it, and that's going to be every week, constantly hearing, constantly listening as we're doing our kind of delivery, which will be iterative. But you've got to listen and you've got to understand. I mean, I'm not clinical. I haven't been on the front line as some of the panel have, but I've also really seen the pain of things going wrong. And like say, you know, the managers, it's like, this is how we do training. And it absolutely blows up in the face afterwards. And that's one of the things, you know, making sure that it's clinically led, but we, from a digital, as I am, enable that change.
Yeah.
And not do it at people.
Good point. And Joanne's come off mute, so I'm sure she wants to add.
Yeah, I agree, and I completely agree. And Susan's put a question in the chat as well, saying, would you agree that there's a lack of explaining the benefits of using an IT system to frontline staff so that it'll help them deliver in their role, deliver better patient care? And she feels that vendors deliver a system that people are just expected to use. And I'd go so far as to say it's not just vendors. The digital teams in our own organisations are just as guilty of that. They think we will build this system and it'll be fantastic and everyone will use it, but you absolutely need that frontline involvement for people to be able to say that doesn't work for us, we use this workflow, we do it that way instead, because not every organisation is the same.
Yeah, absolutely. Anne, you've come off mute. Do you have something to add?
Yes, I think we also have to bear in mind the other teams in the hospital. We can plan things as well as we like, but you can guarantee that the back-end IT infrastructure teams will say, I'm afraid all the PCs need upgrading from Windows whatever tomorrow. Because they are a bit more isolated from the front line. So you can put in whatever you like, but there'll always be sort of your own team trying to sabotage you. because they're looking at a completely different thing. They're looking at security of systems, which is great, has to be done. But I've found there always seems to be this mismatch between teams. So you can get everybody on board, but then as soon as their computers go down for an hour because they're all being upgraded, you've lost all that goodwill you had.
Yeah. So do you think that, I mean, this is where my project management roots come into play. Do you think that that is the lack of a good quality project plan that sort of outlined all these kind of risks and issues that you know haven't been thought about up front, and then they're a nasty surprise in the middle of the project?
Because people are still working in silos. So you can have a brilliant project plan and think you've thought of everything, but there'll still be a group of people over here.
It wasn't thought about. Right. Interesting. Does anybody else have any experience with something similar where you've had something out of the woodwork?
If I can jump in there, I totally see that. You know, being part of the digital team, I have definitely seen the kind of, it's going to be great, we'll just do it at people type thing, like I alluded to before. But one of the things that I've tried to do, like I refused to start this project until these nurses were on board. No, we're not doing it without them. We're not picking what we buy without them. But also from kind of the infrastructure side, I've brought our solution architects, some of our tech teams to those sites, and actually they've spent a day with the clinical teams to understand what we're trying to solve, so that they're not kind of behind closed doors and it's an abstract idea to them anymore. They've literally sat there, you know, followed a patient round and felt the pain of, I can't find this machine doesn't work. Well, actually, I have to go to a different one to do that different task. Why? But getting that buy-in early on from all teams. So I would say that the governance isn't right early on if you've not got a broad spectrum, a multidisciplinary team in your project. It's easy to think business change, operational, and kind of the vendor side of things. But as Anne said before, you really got to do the rounded approach, your servers, your cloud, to your end user devices, all of it. And your Wi-Fi, that's the other thing. Don't implement a system if you've got Wi-Fi black spots and expect it to work.
I feel like we've had an epiphany. That's right.
I think also just to come in there is just about, you know, it's right. It's about that ownership as well. It's that we can never assume that, you know, we've got change happening at, you know, in our political landscape that will impact our national strategy, which will then feed down to our regional strategies, and then will feed down to being implemented at a local level. And we can never assume that the vision is shared on the ground within the workforce that comes from the top. I'm just going to throw this in here. I just want to do a quick thing to kind of just like explain a bit about how we assume things, and they get lost in translation. So I'm going to say, if I'm going to give you a word, and I want you to tell me the first thing that comes to mind when you think of this word. So I say the word is apple. So Helen, tell me, first word you think of when it comes to apple.
Mac.
Yeah. Devika?
Free.
And Debs?
Pear.
There you go. There's just a really quick example of, we've got one word and we've all made different assumptions on what that word means to us. So from the top to the bottom, that clear communication and buy-in needs to happen if you really want that successful adoption and spread of a technology, because we're so good from a system supplier perspective in digital health is we think success is our go live.
Yeah.
That's just the beginning of that journey. Afterwards, how are we using it? Why are we using it? And if you don't get the buy-in, and if suppliers of technology, regardless of generation, not looking at planning it, the training is great, but there's a real big piece, I think, in that we need to get it right at the beginning before we design that. You know, training will come easy then. But yeah, that's just my kind of like a thing at the moment, that some of those barriers that we're seeing around that hierarchical change management that comes down isn't really being translated well on the ground.
So So I know I'm going off script again, but I'm going to ask you this question. Do you see that the supplier of the software has some responsibility in this, in that when we sell you a solution, we should be coming in and maybe going through a change management process with you, walking the floors with you, understanding how our product is going to be used so that we can introduce change in a more efficient sort of thoughtful way? Or do you think that this should be done even before you procure?
Absolutely. This, do not sell to us, with us. And I think before you're trying to put a square peg in a round hole. If you go, oh, I've got this brilliant idea I'm going to bring to you, well, we know if those features are something that we need on the ground. You know, just because it's got a great brand, it's got a big label, doesn't mean to say it's going to do what we want it to do. So before you go and map out your roadmap, do a bit of discovery with some of your key suppliers on the ground. Understand, okay, how is this working? What are the benefits? You know, sorry, what are the barriers? What are challenges? What would make this better? And then create a solution and come back and say, we think this is going to work for you. So yeah, I'll be interested in, you know, coming. I think Debs wants to come in there and pick up.
Yeah, again, I agree with everything that you're saying. I think one of the things that we might be missing is that those conversations generally are happening with the people that have got the money. So, you know, it's almost twofold. We need a two-pronged approach to this. We need the group of people that are going out and they are selling what we can deliver, and they're talking to the people that have got the money, and those are the people making the decisions, with that disconnect of the people on the front line. So we almost need, as suppliers, another group of people that are able to go out and talk to the guys and find out what their issues are and how our solution is going to make things easier for them, address their concerns, talk about any mitigations for risks. I don't think it's a one size fits all. It cannot be one group of people because money talks.
Yeah, that's interesting. Really interesting. How about any Davika? Sorry, I need food. Davika, do you want to come in here?
Yeah, I was just gonna bring in a point, like, exactly what I think it's Charlotte was said, was that any discovery piece that happens, user research is a very, very key point to it, because that's where they interact with the frontline people. They actually know the frontline is the people who are doing the job, who are interacting and providing this service. So they are the people who know what's required. And at the discovery piece, when the anything is being planned, at that point, user research, if that's done, and if what the outcome of the user research is used to actually plan the rest of the journey, getting this roadmap through and getting the program delivered, that's where the difference is. And anything that's successful that needs this piece of work, if that's being missed out, if we don't know what the user wants, and just keep on delivering anything that what we think is right, that's really not going to help at the end of the day, because you're looking at A but you want a B. So
yeah.
Do you think that message gets lost in translation though? Because, you know, going back to something that Nicola said about, you know, the people that are making the decisions at the top aren't always aware of the implication it has on the people on the bottom. And if we've already done this successful discovery and we've highlighted all of the risks and we've managed to convince that workforce that this is going to be amazing, then it goes off and it's Chinese whispers, it gets lost in translation. You know, how do you deal with that brick wall then?
I think I'll use my phrase again in here. Everything's clinical by default, as we say. And any work that happens, I think the clinical input in everything is quite crucial. So user research, if users are going to go and ask, if a user researcher is going to do that, they really don't know what are the right questions to ask to get the right outcome. And so it's the clinicians needs to be involved with that. So it's like interacting with, it's multi whole multidisciplinary team working together, different professional groups. So that's the outcome. And when it comes to as an outcome, again, there is an involvement of clinical input at each and every stage of this roadmap. And that's where we get the right messages through to the right people.
Having those clinical ambassadors, isn't it,
Exactly.
really?
Yeah. And Anne, you're delivering change at the moment. Are you're having an EPR, is that right?
We are upgrading our EPR. It's
Right.
quite a big upgrade.
Right. And is this something that you feel that the people on the shop floor were sort of brought into the decision making early enough, or are you finding the struggle for change because perhaps the wrong people made the decision?
Our issue was that the original implementation was, I nearly said a very rude word then. It wasn't good. It wasn't good.
Challenging.
Yeah, challenging. The people responsible are no longer with us.
Okay.
So we've been sort of fighting a losing battle, but hopefully we're turning the corner, because we're making a massive effort to get everyone on the shop floor involved in. I mean, they can't design how the product's going to be. The product is the product, but we're getting them involved in the testing. We're getting them involved in groups. We're giving them
great
takes. You know, there's all sorts going on to get them engaged, to try and get over that awful time when we implemented, and to try and get them to have a more positive view of the system now.
Yeah, that's great. And you bring up a good point there. So getting people involved. So do you guys have any ideas on so you don't get the nobody told me when you're influencing change? So and I know we're coming away from the age group, but I know that I've been involved in implementations myself, whereas if you don't involve, for example, the group of nurses, then they do the nobody told me, and therefore they're not interested in adapting to the change at all. Do you have little techniques? Do you get them involved in the testing? You know,
if there is absolutely anybody in our trust who says I didn't know about it, then they deserve to be sacked.
Fair enough.
Put so much effort into going out ourselves, floor walking, talking to people, having little focus groups. It's on all the nurses' meetings. It's been passed down through all the hospital meetings. It's impossible to ignore it. There's posters everywhere. We have completely overwhelmed them with information. So they may not be on board with going with it. Hopefully they will be, but they cannot say they didn't know about it.
Oh, because you're definitely talking about it. Nicola, you've got your hand up.
Yeah, I was just going to say, I think there's phenomenal power in having allies in different areas. So, you know, having kind of a phone a friend in the nursing team, in the medics, in your medical records, in your different areas. And this is what I mean, kind of digital champions, or you can do it in different ways. But I think there's so much power in, let's take a ward, for example, in actually those nurses hearing maybe the sister talk about it, or charge nurse, and actually, yeah, I'm really keen for this change. And suddenly it's not digital doing it at them, or, you know, I don't understand the benefit, because it's their peer explaining it to them.
Yeah.
I think I'm massively getting away from it here, but I think there is a disconnect between the benefit. I think it was Susan that mentioned before, when it's seen as an IT system rather than a clinical system.
Yeah.
Big one that I'm struggling with at the moment is where it's technical change to say, you know, address a cyber vulnerability, when it's not delivering clinical benefit. How do you get that buy-in? That's incredibly hard.
Absolutely. So what about those, you know, we talked about it when we were talking about age earlier, but actually I think we've come to the conclusion it's probably not age, but there are definitely some people that are more computer literate than others. What are your techniques for dealing with those people that are struggling, like don't know how to use a mouse? Because they're still out there, right? And I said back in the day I used to get them in front of the solitaire, but solitaire isn't on computers anymore. So what do we do for that?
It's honest conversations with those individuals, you know, like privately, but like, let's just have a chat. Like, what is it that's scaring you? And sometimes it's kind of a fear of, I don't want to put my hand up in a big group and say, but you know, have your eyes and ears open and watch out for someone who might be a bit hesitant, and just discreetly have a chat.
Yeah.
There's a lot of benefit you can get from just going, are you okay?
Are you okay? Brilliant.
Help.
Yeah.
And
And
I think
again,
in a training session, that doesn't always happen.
no, and that's something that you don't necessarily pick up on Teams. So when you're
Yes.
delivering training by Teams, you're not going to see that.
It's easy
So
to hide on Teams.
yeah,
It's really easy to hide.
The
yeah,
Camera off,
the
mic
people who
muted.
can't aren't generally the issue. It's the people who won't.
Yeah,
oh,
definitely.
that's interesting. Yeah, I've definitely met those people as well. They're
I've,
just
speaking of which, I apologise for not putting my hand up, but I don't seem to have an icon for putting my hand up.
that's fine. It's in the love heart if you need it, but that's fine. So yeah, I mean, with that in mind, there are those people that are deliberately obstinate and they just don't want to adopt change. And what do we do then? Do we have techniques for that? Joanne, you've got your hand up. Do you have a technique?
Sorry, Charlotte had a hand up before me. I don't know if you want to come in first, Charlotte. I was going to say, I was going to say, actually, if anyone uses the Future NHS platform, NHS England have got a change management toolkit, which is really good. So it's open access for everyone to use. There's lots of tools that you can download that will help with things like this. But my other point that I wanted to make was kind of conversely to this, and it was something that Anne mentioned before about and when the system goes down. And I think that's something we need to think about, because particularly generationally, we've got a generation of people now that have come into the NHS never having used paper processes.
That's
never
true.
written a paper prescription, never documented on an OBS chart. We need to make sure that we are testing our business continuity processes and having simulated downtime, because the first time these people have to use paper processes, you don't want it to be in the middle of a critical incident.
Absolutely.
And that's something that we need to be mindful of, that we don't use that, we don't lose that generational knowledge of how we did things before.
Yeah, that's really, that's really wise, because I can remember when I first started years ago at JAC, our downtime was always paper, and we were moving people from paper to electronic prescribing, and people were that was like really foreign to them. They did not understand it. And now people come out of university having never written on a paper drug chart. So you're spot on with that. And that is a generational difference. So you're right. Charlotte, did you want to come in now?
Yeah, I'm a bit late, so I'll just catch up on some of my thoughts and reflections on what's been talked about. I think two things. One, absolutely around, that messaging in terms of that digital maturity of our workforce, I guess, is, you're right, having those difficult conversations. And I think that comes more from good leadership rather than management. We manage a lot of systems and processes, but we really need to start leading people. And that's I understand that's probably a whole new topic, but especially it is about, if we want to go back to that personalized training program for people, it's having those difficult conversations to really understand where they are in terms of, yeah, and I think just I love that, not losing the skills that some of us have, and really understanding when we do that user research that Devika was talking about, and absolutely it needs to be clinically led. But from my perspective, being the voice of the underheard, is it's not just clinicians that use the systems. We need to be engaging with the operational managers, the secretaries that have their turnaround times for letters, everyone who touch points into that system really needs to be part of that user journey to understand where their unique needs are in terms of those features. So yeah, there were just two things I wanted to throw in there.
No, I think you're right, and I think, going back to the preparing up front that we were talking about earlier, these are all important points, but we need to do all of that at the same time as balancing it with the fact that implementation has to be a bit slicker and probably faster, because the NHS is underfunded, as we know, and we don't have the luxury of time to take years and years and years to deliver a solution. We kind of need to get most things done within a year, don't we? So almost the upfront planning is the important part, right?
But I think also we talk about, you know, some of us here, we all talk about digital transformation and we know what that means. You know, it's a buzzword, but I guess to some people on the ground, that just means IT change.
Yes.
And that comes a fear and a pain. Am I gonna look stupid? Do I want to put my hand up? You know, am I gonna lose my job because automation and AI is taking over? You know, is it gonna make, you know, me lose that patient care, which is part of why we became frontline staff anyway. So it's like, I guess, to question out, and probably to Anne, who's the psychologist within us, how do we adapt to change? Because it is so fast paced, and we're talking about, we need to bring it in, and by the time we've got used to that change, it's changing again. So how can people adapt better to change?
Yeah. When you look at all the traditional models of change and how people adapt and all the different, you know, there's the acceptance at the end. Once you've gone through all the upset and trauma and rage and all the rest of it, we don't actually have time for those cycles to play out anymore, those traditional cycles. Like you say, it's just again and again and again and again, getting quicker and quicker and quicker. So I think we need to start looking at some different models of how we help people adapt to change and how we get people to accept change, because I don't think that the existing models actually fit what we're going through nowadays.
Yeah, I think you're right. And I think us suppliers need to take some responsibility for that where we can, because, you know, we're delivering change. So it's our responsibility, and we've done it before. So we've done it in other organizations. We should be able to learn lessons from that and introduce it better.
It's also, I know one of our suppliers, instead of doing a really big upgrade once a year, they're putting out smaller upgrades during the year. But for us, that's just as much work.
Yeah.
Because it still has to go through our change board. We still have to get it approved. We still have to get IT, you know, the back team on board. We still have to test it. We still have to implement it. We still have to train everyone. So it doesn't actually help us having lots of smaller upgrades rather than one big upgrade.
Yeah. And when you've done all of that and then you get to the 11th hour and find a bug that you can't introduce, and it's back to square one. So I completely get it. So we got 2 hands up. I don't know who was first. Did you have to guide me, Nicola? Sorry. Yeah.
I think for me, this is where kind of automated testing can come into its own. And this is a bit of a plug that I'm trying to do at the moment. You know, the manual testing, it has its space and it's valid in some areas, but actually there's a lot that you can do with automated testing. You know, your standard path or paths can be regression tests, and that can be done in minutes with automated testing. I'm not saying, Anne, that, you know, we should do lots of mini ones, but there are things that we can do that can make this far easier. So you're testing the edge cases, but in my experience, we've not invested in that yet, or we've dipped our toe and kind of gone, oh, this is a bit complicated. And I think there's a lot more to do in the future. Certainly, I've got a huge program coming up in a couple of years, and automation and the testing of that system will be built in at the start, not an afterthought, for that very reason.
So that's interesting to me. So if I can ask you a further question on that. So assuming that you have to build automated testing, it's not something that's just out of the box. Does that make you guys stickier to the product? So if you buy a certain EPR, for example, you set up your automated testing, you're more likely to stay with that company longer. So therefore, you know, it's worth companies putting time into automated testing. Is that right? Is that a right assumption?
I've got a bit of a mixed estate at the moment. I've got areas where actually the suppliers are looking to promote that as part of a procurement that we're doing at the moment. So it's built in as part of that. But I think I do understand what you mean about you're more likely to stay with that supplier. But I think actually once you've done that thinking about what are my standard flows and how can we automate that, you can then apply it to different systems, because your process, you understand your process then, and you have your test cases of kind of the data that you add as part of those automated test scripts. You have that kind of repository of stuff ready to go.
Really
think
interesting.
there's a mixed bag out there in my experience. But at the moment, like I say, it's patchy at best, and it's kind of done for a few little areas. But
Yeah,
I see
there's opportunity.
impact to upgrades if that was built in. And like you say, if suppliers were going, right, here's our tool for you to
Yeah.
automate your regression.
Yeah,
Something.
it's a different game. Yeah. Davika, did you want to come in here?
Yeah, I was just going to come back to the question that Charlotte had asked initially, and I was pick up one of the questions from the chat from John about the panel feeling about relationships between organizational culture and change. So I would say that's quite important one, and I would say it's really crucial in any changes that's happening. That culture is quite important, and it's all dependent on how the organization interacts with the people who are going to be affected by the change, and that's very important from my point of view. And coming back to Charlotte's question on the big changes that's happening and how to deal with the changes, I would say it's I always say that changes are difficult, but if you break it down into a simple format, like, break it down into small pieces, like what we do, like Helen, you will be aware about the agile technology from agile from the project management. If break it down in small pieces and then take it forward, that would always be one of the best thing to do from my point of view.
Yeah.
And anytime that I've faced the problems, and I've been told that, okay, you need to do this change right now. It's necessary. And I take a step back because I know that that's not my capacity to do. That's not how I like to work. So at the end of the day, I'm still, even though I'm using the agile technique, I'm still achieving the targets. And that's what is important. Rather than rushing for things, go with the flow, but slow and steady wins the race. And that's how we still get to the point. So that was something that I was going to bring in. And in terms of what something Anne had mentioned about there are too many big changes, but they have delivered in small pieces at that time. So I would say, rather than I totally absolutely agree that if there are too many changes, too many change requests happening, and then it's frequent training and frequent user acceptance, then the user who's going to have these changes is going to be massively impacted by that. So I totally agree with the fact that it should be all in one go. And if that's a problem to deliver, then it should be maybe used with the standard. I believe that in most of the places they do that in a pilot site where they train the best area that they are going to work towards that. And from there, develop the trainers. So train the trainers and who can help deliver the training further, one-to-one training to let them go across different areas where you want to actually make this change happen and get that delivered. So I would have rather taken that approach. So yeah.
Brilliant. Thank you. And Charlotte, you have your hand up. Do you want to come in?
Yeah, just I'm interested in understanding from the group, and it's from a selfish perspective, I guess, in terms of mindset of the workforce. That barrier to change sometimes can be from a mindset perspective. And does that, the younger generation seem to be more open to meditation and mindfulness and, a mental health being more open, inclusive and diverse maybe than some of the older generation. And I'm not stereotypically anyone, but just from my personal experience, that's what I've seen. Do we think that in terms of going back to that training, is there a responsibility for us to be putting in mindset resilience training into systems training as well to deal with some of those fears that we're seeing from those generational differences?
Okay. Who wants to jump in here? Nicole?
I would totally agree that we do. There is an awful lot of fear around change. I'm experiencing it less so because the area I serve has had so little change that they are desperate for it. So I'm in a very happy place at the moment in that everyone wants the change and wants it faster than I can possibly deliver it. But historically, there's so much fear around it. And what does that mean for me? And like you said before, does AI suddenly mean that I don't have a job anymore? Actually, we should be thinking, like you say, in a more mindful way about how we deliver this training, what it means. And I can't remember who asked the question much earlier, but about the benefits and baking that into the training as well.
Yeah.
We're training you on this, and this is why, and these are the patient safety things that we're going to address, and these are the, you know, even if it's financial benefits, be honest about that.
Yeah.
This is going to make it easier for us to bill, or this is going to make the data capture that we do more accurate. I think all of that should be part of it.
Yeah, money is a relevant
Hide
benefit.
the bits in the business case like that. Let's be open about what it is and why we're doing it for everyone.
Do you, where does the responsibility in that mindset type of resilience training, does it sit with the organization in terms of the NHS or the service that is implementing it, or does it sit with the supplier in saying, actually, this is, you know, we want to support you through change with, you know, different tools in your toolkit? Or is it both?
I think it's both. I mean, in some of the procurements that we're doing at the moment, we've asked suppliers to show us what best practice looks like in some areas where we've got less mature services or less mature ways of delivering the tech. So I think there's a little bit of both. I think there's definitely something on kind of the accountable executive of projects to lead and programs to lead it at that level. If you try and tackle kind of just big organisation, especially one like mine that's across England, that's really challenging to do. But I think Davika said slow and steady wins the race. Let's pick it off and actually show what good looks like by doing it one really well.
Yeah. Yeah. Debs, you had your hand up, but you put it down again. Have you not got anything to add now?
No, it's an agreement again that actually, yeah, that responsibility comes from both parties, but how we actually implement those sort of safety procedures or whatever terminology you were using to describe it, I don't know the answer to that, but I think that being able to have conversations with the users that are experiencing the issues and openly acknowledging that there are risks and openly acknowledging whatever mitigations you've got, and being in the position to almost offer a personal approach to their issue is you know, that's faultless. That's if you can kind of associate yourself or and give the impression that you understand that the pain that they're going to experience or not, I think that goes some way into helping them to be able to manage those stresses and strains. Absolutely.
Brilliant. How are we doing in the chat for questions? Do we want to hit anything that I've missed?
So John has brought up a good point. Do we think that the creation of a safe space where failure is seen as a learning exercise have the potential to improve change among the workforce? Fear has come up a few times in the conversation. How can we alleviate fear?
Really good question. Do you want to say anything yet, Charlotte? You got anything?
For me, it's such a big barrier to change, to transformation, you know, and alleviating that. I think that by being vulnerable and sharing that the failures and doing those lessons learned from, you know, from a supplier's perspective, sharing where, you know, with a new prospective client, this is the things that we've gone wrong, this is the fears that, you know, that we've seen. I think, yeah, just being vulnerable and authentic and saying, do you know what, we didn't get it right and I am scared. And we talk about courage, and courage is knowing that you are scared but doing it anyway. And I think that's the kind of grit or resilience that we need to build within our workforce when we're implementing change, is creating that safe space. And I love that, you know, in terms of let them fail, you know, positively, and that's the courage that they'll take to adapt, I think.
Yeah, absolutely. Debs, you got your hand up?
That authenticity needs to come from the suppliers as well, though, doesn't it? It's not just the workforce. We almost need to be able to show that there have been failures and to understand that this is what we've done to make it better. Just kind of having those, it's not just the workforce's responsibility, it is absolutely ours as well.
I think you make a good point, because as suppliers, we often tell the good news story. And John, you'll know this. I'm calling on you because I know you very well. And as a marketeer, we often tell the good news stories, but do we ever tell what happened, what went wrong, but how we fixed it? Because we always do come in and fix it. We can't leave a customer out there hanging. So there are some things that go wrong, but actually that's a story in itself. This went wrong, but this is how we fixed it, and that should help alleviate some of that fear as well. So I think you make a good point. Anne, you have something to say?
It's a slight tangent, but sort of connected. It was something I was keen to bring up, in that we're putting all these systems in, and they're to help the end users, to benefit the end users, help them in their roles, make their roles easier. But it's having the opposite effect on the support teams. The amount of tech that we are now supporting is astonishing. And we always said a few years ago, we were taking the pressure off the band 3s, 4s, and putting the pressure on the band 6, 7s, because they were then supporting all these systems. And the more systems we're putting in, the more we're having to support. So as well as it being really, really important that we bear in mind the people we're putting systems in for, we also have to bear in mind the people who are putting the systems in, because they're going under just as much stress, and going forward have to support those systems.
Good point. Really good point. Nicola, you want to add? Nicola, sorry.
Yeah, I think definitely exactly what I was saying there about kind of the people to support it. I think selfishly, but digital is kind of an underinvested area in terms of the staff to support. We're very good at spending money to bring a system in, and I think there's maybe something that suppliers could do to help us by saying, actually, this is the team that we sort of expect support our system. This is the number of conversations I've had where I've had to justify why I need another member of staff, when you've got people around you crumbling under the pressure. But it's like, well, how do you justify? The question I get is, how do you justify that over a nurse?
Yeah,
I've had that a number of times. It's like, well, but we can't help serve the rest of your nurses if we all fall over. It's really difficult.
Yeah, you make a good point. And definitely years ago, like I said, I worked for JSE. It's not a thing anymore, JSE. They're under System C now, but back then in the contract we were putting that to implement electronic prescribing, for example, you need a system manager. So it was in the contract that you had to have a system manager, and that system manager needed to be a pharmacist or somebody of that clinical eke. I don't know if companies all do that anymore, but I think you make a really good point. Anybody else have anything to say around that? No? I was just going to ask, we picked up on really, really quickly earlier, I think, Nicola, you said about AI. How do you feel about AI? Is it worrying you at all? Or do you see a potential benefit here?
I'm not worried. I think there's an awful lot of scope for AI and machine learning. I think for me personally, the amount of maturity that we're going to need to do to get there is actually quite frustrating. I feel a little bit left behind in some of the projects and programs that we're doing. But there's so much that you can do there. I mean, you can back to kind of my hospital days, but looking at indicators for sepsis and things like that, and having things that are automated that can trigger early warning. And there's all sorts of studies that have been done, retinal scans that can actually detect whether you've got liver disease and all sorts of things that are out there. But the key to that is having the data to support that.
Yeah,
I think that's certainly where we as an organization need to mature, because a lot of it's paper right now.
Yeah.
So excited rather than nervous for me.
Yeah, brilliant. Charlotte, your mic is off. Do you want to say something?
Yeah. Do you think, though, whilst yes, we need to be ready, but does the workforce need to be ready in terms of that education and awareness? Like for me, it's taken me a while, but do I still trust a person more than I would trust AI. What I didn't realize was AI has been in my life forever. Netflix runs on AI. It tells me, brings up, this is what it's going to be, you know, we've chosen for you. I never realized how much AI was already in my own life cycle, you know, in terms of what I do daily, but I trust AI? I would rather have someone tell me, you know, and that's just my perspective at 50, which is like, oh, but yeah, all the hands will come up now. So yeah.
We started it. Who was first then? Anne, I got you first. Or you first? I don't know who's first.
Yes, I'm really excited. Do you know what? I think I've forgotten what I was going to say. Oh yes, I'm really excited about AI. But there's always a but. I'm very aware that we already have some systems in place that will do some monitoring of patients. I remember a talk by some Sir somebody or other where he had envisaged this warehouse full of people remotely monitoring people on CCU, and then if their obs changed, then they'd phone up and say, please look at Mrs. Smith in bed 3. They're missing out on the fact that a nurse can look at a patient and go, there's something a bit off about Mrs. Smith today, and it won't show on their obs and it won't show on any of the reports. But that human interaction is enough for them to realise that there's something not quite right that needs looking at. So I think we've got to be careful that we don't lose that.
Yeah, lose a human. I think you make a good point. Davika, are you next?
I think, and you just almost said what I was going to say, but I was just, yeah, I absolutely am an AI person, a very tech savvy, even though ignore my age, I'm still 16. So I'm really tech savvy, and I'm absolutely with accepting what AI brings into. But then again, there is one fear or one somewhere where my age comes in where I'm a bit like, I don't trust you. So what Anne has said is like, it needs to be a really fine balance between AI and human interaction, and we need to know where to stop. We don't want to give the full control to AI as well, because that's what it does, but still there needs to be that fine line where human interaction is needed. So there is loads of things, like I'm giving you an example again about writing the notes for my consultation. Then I can just use the AI tools and dictate it, and it just automatically transcribes it into some words. I don't have to type it. Then those kind of things, yes, acceptable. But when it comes to like the example that Anne just gave, yes, you really need a bit of a human interaction. So it's a fine line between where it is, and that's where I would like to bring in clinical safety, or being a clinical safety officer. I would just like to bring that, but even though it's still not up to that level, but that's where you need to assess what risks are. What do you want to do with that, and then decide where you want the AI. Do you really want a full AI picture in there, or do you want it to be partially and you want the human interaction in there?
Yeah. And is it saving time if we're having both? Nicola, you want to come in?
I think it's definitely got a place in aid and decision support, but I really don't think it should replace it. Not yet, anyway. I don't think we're ready for that. I think, like Charlotte said, I wouldn't trust it. I don't think I'd want my care to be decided by AI either. You know, if you got in hospital and someone told you actually this has made a decision. But I think the other part to this is kind of in areas where we're heavily regulated as well. You know, AI should only function up to a point, because then things become software as a machine, software as a medical device. Sorry, got the wrong word in there. And then you need to CE mark as well. So I think there's a very fine line that you need to tiptoe, and I'm trying to be quite conscious of that in the things that myself and my team are building right now. That we present the information to people, we present how the system has come up with that information, and then, you know, whether it be nurse, clinician, biomedical scientist can make an educated and informed decision on what's being presented, and can override if appropriate.
Yeah.
So I think if you're tread into kind of needing to CE mark stuff, then it's exceptionally complicated.
Yeah. And oh, Erin, you had your hand up. Is that gone?
Yeah, I was just gonna, say that that's sort of echoed by Melanie in the chat. She said AI relies heavily on data analytics. For AI systems to function effectively, it requires large amounts of data to learn patterns, make predictions, or perform tasks such as image recognition, natural language processing, and decision making. So yeah, I think the point you made, Nicola, there about it aiding is really important. But do you want it to control? Maybe
Yeah.
too early for that.
But when we talk about AI on medical, I get everybody's a little bit nervous about that. But what if we could use AI to do some of the testing in our implementation process? I'm assuming it can. It's pretty clever stuff, right? Or are we willing to trust it for that? If we could trust it for that, if it's a thing, I don't know.
Aren't we already in automated testing?
So we're already doing
we're programming it in a way to kind of do it for us, and we're trusting the results there. I think we're already part of the way there. So
we're willing to do that, but we're not quite there yet on it being a medical device. I think then in that case, that's what we're saying. Davika, do you want to come in on this point?
Was going to come in on Melanie's point, but I can say something on your point as well. So I'll start with what Melanie said in the chat. And yes, that is a very valid point about how does the AI work? It works on the data that's been collected and the data analytics that runs behind it. But in the healthcare system, to have that enough data to run those analytics, we don't know if that's well enough to actually get the data and that automation run behind it, so that gives that accuracy. So it's something to look to, whether should we accept that as a decision support tools or not. And that's a really good point that you made, so I just wanted to second that on that. And the other thing what you mentioned, Helen, about sorry, now amnesia, I forgot that. Sorry, what was the question again?
I was saying using it for testing, if that's the thing.
Yeah, sorry, yeah. So in terms of testing, I think that there are it depends on what kind of testing it is. There are certain things that it has to be done manually. But yes, it saves a lot of time if there is some automation that's happening. So say, for example, somebody mentioned about the infrastructure not working right. And when you connect to systems, those testings, yeah, that can be done automated. And we know that that's the messaging has returned back as the right message has returned back. That's fine. That's a tick box. But certain things which you actually need to do manually, that need, again, I would say there is a fine line between what needs to be manual and what can be automated, but certainly it could be helpful in so it would reduce basically quite a bit of time in testing.
Yeah. Charlotte, did you want to come in?
Yeah, I know we're almost out of time, so I'm just gonna, I think, bringing back the generational thing is that the younger generation seem to blindly accept AI, whereas the older generation may be a bit more apprehensive. So I think when we're doing that training, there's some education to the younger generation about actually what it is doing, but also maybe some, alleviating some of the fears that we have at an older generation perspective. I think it's great. I think it's wonderful, but just bringing it back round to that training, I think different generations are more accepting of it, sometimes blindly, and we also need to address that as well.
Yeah, absolutely. Brilliant. I did see John said one more thing. He said AI is increasingly being used in some clinical use cases, radiology first readings, but the second readings is still carried out by a human. Good point. That could save 50% of resource, especially on standard cases. It's been great track record for recognizing common ailments from chest x-rays, freeing up clinicians for specialists and more complex cases. So that's a really good point. Okay, I'm going to leave the AI chat there, and I think we're going to head on to our last question, if that's all right. And this one is just simply, what do we think the future looks like for the NHS workforce in terms of digital transformation? And what do you think the next generation is expecting? So basically, what do we think our future looks like, but also what we think the people that are coming in, our I don't even know what the next generation is going to be called if we're Gen Z. Does anybody know what the next generation is going to be called? What do we think it's going to be like for them? What's that for, Charlotte?
Anyone that's born now is an alpha.
Right. Well, what do we think the alphas are going to think about all this? Anybody want to say anything? Have you got any predictions for the future? Nicola?
I think we've talked about this in our other chat, but I think there's an intolerance now where there is a lack of digital tech, and we're losing staff when they come into our very heavily paper services. You know, they go and work in hospitals, like nurses go and do their training at digital exemplars and then come and go, what is this paper? No, thank you, I'm off. So we have to catch up rapidly in order to keep a workforce and to move with the change that they expect as well. And that is a very fine balance when you take on board Anne's point before of change overload and how do we do it? Because lots of different upgrades is too much. But I think there's an intolerance to waiting now as well.
Yeah, that's a really good point. Does anybody else have any predictions? Charlotte, you're off mic, are you? Have you got a prediction?
I think we have to be open to listening and learning and observing what are the key kind of like findings and themes going on outside of healthcare as well. We see that some of the things that we're using in healthcare have come from outside in terms of, you know, I think Careflow uses almost like a Facebook Messenger type thing, you know, so looking, I think they're just going to expect something different. But if I'm honest, I don't think we know what that is, because what we've seen here is that actually it's not generational. There's a lot of other things that factor into what the digital transformation of the future looks like.
Yeah. And Claire, she's from Restart. She said that her kids are 10 and 12 and they're already learning coding at primary school. My word. They're so advanced that it scares her. That scares me too. And I think we'll see a rapid change in the next 5 years. And I think you're absolutely right. But that means us on the shop floor need to catch up. Davika, you got your hand up?
Yeah, so that's a really good question that you asked, Helen, about where we would see it next, where we are going next, or what could be done. And I am, again, a good advocate of a happy path of health and technology working together, wherein I'm expecting that everything, all the data that has been captured in the systems of beforehand, if you remember when we started, the drugs that were coded in the system were anything that was randomly in the health system. And now that we've got like standards to follow, the digital coding that's come in, like DMND codes and everything we use. So we have now got the structured format. So which means a system talks to another system in a coded language, which means we've got better data, which means we can, there can be the analytics that can be run through those data. So my vision is everything perfectly coded, and everything perfectly coded with that data that we have received, we can use it for the better data analytics, which means data-driven care and systems talking to each other. At the end of the day, patient will receive the best care out of it. Again, other thing I was thinking about was patient empowerment. So these things like I would say patient looking at their own data and then actually being able to do what they want to do using that they've got, then it's something that I would say is something that quite crucial for the future, and it may happen. I don't know. I'm being very optimistic in here, but that's what my vision is.
Brilliant, brilliant. Anne, did you want to pop in?
Yeah, I think the tech is going to advance with or without us. I think certainly from my generation, now that I'm reaching the end of my career rather than the beginning, I think the responsibility on us is to make sure the structure's there to facilitate it. So the training, the implementation skills, I think it's on us to make sure those are in place. So as the tech comes in and it speeds up, that's there ready. Yeah.
I think you're right. And I think following on from that, that's also where the suppliers tag in, and we need to make implementation easier. And I think some of the ideas that came up during this talk are absolutely viable, and we really do need to be thinking about them. Does anybody else want to come in on this last point? No? Is there any other questions in the chat that we've missed, Erin?
No, I don't think so. I think we've kept up to date nicely with that.
Brilliant. So I just want to say thank you so much for this talk. I've learned, I personally learned a lot, and selfishly, that's kind of what I wanted to do. I wanted to come here and talk to my friends and understand their thoughts on implementing software, and I think we've come to some kind of conclusion that whilst age perhaps has some impact, it just doesn't have the impact that I might have first thought it did. So I just wanted to say thank you so much for your time. Did anybody else want to say any sort of final words before we log off for the evening? No? Brilliant. Well, in that case, I'm going to say this was a great success. I hope to do this again. I really would like to do it in person with wine and cheese at some point. And I'm so grateful for everybody giving up their evening and coming along and listening to us talk about how we can improve change for the NHS. So thank you very much.
Thank you, Helen, for organising as well.
Thank you. Take care, everybody.
Bye,
Thank
guys.
you, Helen.
Thank you. Bye.
Bye.